This is a panel discussion on Ujvira in 2022. Where does it stand in your practice? This session is sponsored by Zydus. It gives me great pleasure to introduce our chairpersons, Dr. Rosina Ahmed, surgical oncologist from Kolkata, and we have Dr. Ghanshyam Biswas, medical oncologist from Bhubaneswar. May I invite you to the stage, ma'am and sir? I'd also like to invite our moderator, Dr. Joydeep Ghosh, medical oncologist from Kolkata. And with sir's permission, I'll just introduce the panelists. So our first panelist is Dr. Ashish Singh, medical oncologist from Vellore, Dr. T.P. Sahu, medical oncologist from Bhopal, Dr. Partha Roy, medical oncologist from Guwahati, Dr. Vedant Kabra, surgical oncologist from New Delhi, Dr. Neha Chaudhary, surgical oncologist from Kolkata, Dr. Dipti Rana Samanta, radiation oncologist from Cuttack, Dr. Prashant Mehta, medical oncologist from New Delhi. We have Dr. Shefali Sardana, who has joined us virtually, medical oncologist from New Delhi. We also invite Dr. Chandrakanth MV, medical oncologist from Kolkata, to join us. Thank you so much. Over to you, sir.
Thank you. Good morning, everyone. So we'll just push off without any delay. So we will talk about the TDM1, its current practice, its current acceptance in our clinical practice. So this is a baseline of how the drugs work. We have the larger molecules acting from outside the cell membrane. We have the smaller TKIs going inside the cell and blocking the receptors, and that's how the downstream signaling is affected. Now there is a trial, it was a phase 3 trial of TDM1 biosimilar study, which was published in Clinical Breast Cancer recently, and it was a randomized open label study. And it looked at the parameters for biosimilarity, which are most commonly the efficacy, safety, pharmacokinetics, and the anti-drug antibodies. So I would start off from Dr. Ghanshyam Biswas. Dr. Ashish, so do you think biosimilar studies, if they keep pharmacokinetics as only primary endpoint, is it sufficient, or do you need efficacy outcome also?
So I think it's important for us clinicians to see that the drug works in the patient, right? So it may be possible to show in the lab to their, the ELISAs or whatever methods they show that it has the chemical, but what about the autoantibodies? How long? What's the half-life in the patient? So,
right.
So I think what you're asking is that do we just look at structural similarity and start using the drug? The answer is no. We would want to at least have not a very large trial, but at least reasonable numbers for us to see that we get some clinical endpoints.
Okay. So if I say that if you have a phase 3 biosimilar study where the primary endpoint is just the response rate non-inferiority, will you be okay with it?
Yes. So again, when you say non-inferiority, that actually becomes a big trial, right?
Yeah. It's a big study. Say, yes, for example, the heritage
So
study.
some clinical study is what is required now. Now, regulatory approvals in our country does not mandate a clinical study.
Right.
But as a clinician, I would like to see one. Yeah.
Fine. Sir, any comments? T.P. Sahu?
No, I totally take it that some efficacy does give us the confidence, but the toxicity is something I'll be more concerned about. I'll look into the safety data much more carefully in a biosimilar. So that's what I think. The three things would be the pharmacokinetics. The second would be safety for me. The third would be the even a non-inferiority is a good enough trial.
Thank you. So moving ahead. Yeah. Okay. So we have also Dr. Shefali, who is online. So initially, there was almost between years 2015 to 2021, there was less than 5% access for most of our patients to TDM1, and now it has increased to almost more than 20% because of the advent of the biosimilar. And as you can see that in this pie, that almost 86% of the usage is in the metastatic setting, and 12% is in the adjuvant setting. So when the initial first 1,000 patients were enrolled in the wider access program, 95% were MBC, but that increased to almost 70. That reduced to 77%, and an increase in the usage in the adjuvant setting, more so in the patients who have not achieved a pathological complete response. So that is a subset which has significantly increased in the recent times. So I think that is this is one really useful addition to our treatment portfolio, because we do have around 50% of the patients of HER2 positive who do not achieve a path CR, and that is where the Catherine trial comes into place. So I want to ask Dr. Kabra, how's been your experience with TDM1?
Of course, when the cost comes down, it becomes easier, because TDM1, be it TDM1 or even at one time it was Herceptin. Even today, not everybody would afford Herceptin. So TDM1 of course was a difficult situation. And in spite of being in a private setup, I would say not more than 20-30% would be able to afford TDM1. And most of them with huge insurances there.
Okay. Dr. Prashant?
So my experience has been, with the biosimilar you're saying, or
Biosimilar
overall with
or the
TDM1.
original, whatever.
So it has been decent, and mostly in the metastatic setting. And probably there has been one patient where I have modified, used a risk-adapted protocol post-surgery. But it has been mostly in the metastatic setting. And yes, I agree with Dr. Vedant that there's a problem of logistics and finances in our patients. It is there.
Okay.
So I work in a hospital which caters to a mixed population and very poor patients also sometimes. And I wish to help them too.
Okay.
So many of them are not able to, most patients are not still not able to take it in the place I work.
Okay. Madam, your take.
I think previously original molecule was not accessible by most of the patients. Since the advent of biosimilar, we are just using, but it is not so much accessible by the common people. I think many more things are required, reduction of the price, anything is required, because I work in a government institution where it is very, not very practical to think of regarding this molecule. And still now also we are using single blocker in most of the cases, and when dual blocker you will think whether you have to add lapatinib, which is very much accessible by the patients, whether to, even though it is not NCCN approved, but you have to think practically what we can do for the patients. And in my opinion, it should be again very much explored by our people, scientists and all, to reduce the price much
I
better.
agree with
for
you
the-
that there is a long way to go regarding the price reduction.
I want to make
Yes.
a point. I've discussed many times. See, I feel for even the above average population still not affordable. That's point number one I want to make. But the only thing is, I don't know how many of us feel the same. I have felt it that once the patient goes beyond 12 to 13 months, then the generic becomes costlier than the original. And I have put it forward very clearly multiple times to the.
Compared to the patient access program? Of
Yes,
the
definitely. So who is not giving a original TDM1 without a patient access? After a particular 4 cycles, it is the patient does not pay for the life. And I have a patient, or 2 patients actually gone beyond 2 years. So that point, I think as a healthcare provider, we have to be honest to the patient to put these 2 facts forward. That once you go beyond that 13 months, 14 months period, this will then become costly to you. So I think that is a very important point.
I think
cost
for
reduction at
the
that
common
point,
people, that assistance also is not reachable.
Agreed point that people can afford the things, then what I'm talking, I don't know others if they share the same.
We have a common patient who is for last
2 years, yeah. She's
because of thrombocytopenias and rising ALT and ST, but she is still continuing. So 2 years, so that's a bigger no. So yeah, so that
what sir is saying that the cumulative cost of the generic is probably more than the
so
patient
maybe after
assistance.
2 years, so if you are using the original one, it becomes
14 months.
14
So
months.
that's the break-off point where it becomes such. Okay, so that is very important. I think that is an important message to the industry also, that after the 14th month, you might not want to reduce the cost further so to match up with the original molecule. So these are the 2 major studies which have changed, which have increased the usage in our setting. In the metastatic, we have the second-line Amelia study, and in the adjuvant setting, we have the Catherine data. So I'll again come back to Dr. Ashish. So what proportion of your patients actually have been using TDM1 in the adjuvant setting in the last 12 months?
So adjuvant is actually a totally different story. I mean, the Catherine, even though it's almost more than 5 years, we are still awaiting some overall survival data. But obviously, with patients with a lot of residual disease after trastuzumab or even pertuzumab based, this definitely reduces relapses. Now, but then again, the kind of place I work in also, maybe I would say only 10% of patients can actually think of doing something more than just trastuzumab. And here again, 1 year therapy is prohibitively expensive. So most of us would actually ask ourselves that does a shorter therapy would give you the same benefit? The answer is we do not know yet, right?
Okay.
Now I agree with the other people. The medicine cost, if you're going to give only maybe a few cycles, definitely having a generic helps. But if you're going to give for a year, 13 cycles, 14 cycles, then it's similar. Right? In terms of
in
price.
your institution, do you have a subsidized price of drugs, or is it the same as?
No, so obviously the price at which the medicine is procured by all of our hospitals are the same, right? You know, and
I think TMH has got a.
so that's the decision they have to make. So I really don't know how is it in TMH and how is it with us.
Dr. Parman, I am also from a TMS sister institute at BBCA, but the rates are almost same.
Same.
Yeah.
Not
It
much
is
of
subsidized is for the original one, not the biosimilar one. So actually, all my panelist colleagues are right. So if we are going for cumulative cost, definitely it is going to be much more higher than originator one.
So moving ahead, we all know that late presentation in breast cancer is one of the commonest features in our patients, unfortunately. So, Dr. Sahu, do you routinely give anti-HER2 blockade in patients who are more than 2 centimeter as the routine?
I push for it. That's the word I'll use it. I am little okay in my city that people do come to me for that pre-operative opinions. But I can tell you, out of 10 I counsel, 8 will ultimately go down and take a surgery. Although I counsel to all of them. So the point is, it's more of a teamwork, and when it is beyond institutions, you have persons practicing, mainly surgeons, who feel that if I operate a 5-6 centimeter, it is okay. I feel we need much more educational effort to push in to be able to give the benefit of around 2 centimeter or node positive, HER2 new positive patients to go for invariably a neoadjuvant intent of therapy, then operate and then go forward. That is a tough job, at least what I see in my city. I don't know how the metros fare, but I feel even if I counsel 10, even this patient feels that if I take it out, it's gone. So it's the shift will take another 1 decade or more. That's what I feel.
So we have a question from one of our panelists, Dr. Shefali Sardana, and she has raised the topic of the value of IDFS as a primary endpoint in breast. So, Dr. Kabra, your take on that. Do you believe that IDFS is a surrogate marker of OS in breast early?
So, if we have no other choice, I think we have to accept it. But obviously, we would like to have overall survival as the marker. That's not ideal.
Am I audible?
Yeah, Dr. Sadhana, you're audible.
Yeah, so just my question, I mean, because we were mentioning that it's the OS data which is still awaited, should we believe on Catherine or not? So in now upcoming trials, be it the olaparib trial in adjuvant setting, or be it I mean any targeted therapy, so IDFS is the key point where everybody is stressing. Okay, the benefit is there. So can we altogether negate this? If OS is not there, should we not use, the biosimilar, or for that matter, TDM1 in the adjuvant setting? So that was the thing in my mind.
If you correlate with radiation trials, every 5 local recurrence used to worsen. It used to translate ultimately into worse overall survival. Probably with a longer follow-up and larger studies, we may get it here as well. But ideal is overall survival, yes.
I agree. If we can get overall survival, that would be ideal. But in a practical world, how long do we wait to get the overall survival data?
I think the main reason is the very long time median follow-up required for early breast cancer. That's why the trials design as IDFS. But I think in breast cancer, IDFS is a good endpoint, and even in the metastatic setting, the FDA approvals come right after a PFS benefit, like we have seen in Palvo and other drugs also. So I think that can be one of the primary endpoints. And Dr. Prashant, what ideal regimen
the thing we have to remember is as soon as you have a relapse, you get put on treatment again.
Right.
And even though we have good anti-HER2 therapies, but still that patient is not enjoying the quality of life or financial toxicity what somebody on treatment would go through, right? Yeah.
At this point, it seems IDFS is a good ideal point. I mean to say we can use a marker, but whether this IDFS is a surrogate marker of OS or not, that is yet to be proven.
I think that is.
Otherwise, in absence of OS, probably
the
we can
OS
use
is
IDFS.
very much decided by a lot of factors.
Right.
Site of recurrence, the subsequent therapies, and all those things. So, Dr. Prashant, what ideal regimen you want to use for a HER2 positive EBC in an NSCT?
So I think I would stick to TCH for most patients.
Okay.
EBC
TCH,
you're using
yeah.
TCH.
6 cycles of TCH.
Yeah,
Okay,
that's what I would stick to.
Great. So we all know that the more drugs we use, the more is the PAT-CR, and the PAT-CR has shown to be having a good outcome compared to those who did not achieve a PAT-CR. So I would come to Dr. Rosina. How do you define PAT-CR in your institution?
So there are basically PAT-CR would be defined as an absence of disease, both invasive and non-invasive, in the breast and the axillary lymph nodes.
Okay.
Though there are alternative views which exclude non-invasive disease from this.
Fine. So this is the Catherine data. We all know there is an 11% increment, reduction in the IDFS, and this data is from our own country. This is from Dr. Gogia, and this was presented, I think, in June 2022 ASCO, and it shows that in the overall population, the PFS was around 10 months with Ujvira, and the OS was around 27 months. So that's quite a reasonable outcome, I would say. So I think we are about to have the next session. So we will just wind up fast. This is the TDM1 activity in patients who are having a brain metastasis. It is shown that probably it is slightly more effective than capecitabine plus lapatinib, and the responses are also around to the tune of around 50 to 60%. Marianne study basically looked at whether we can use TDM1 in the first line in metastatic setting, but it did not achieve its primary endpoint of proving a superiority, but it can be used in some patients who are weak, frail, and who would not tolerate a Cleopatra type regimen. So I think just one question I want to ask to my panelists. Any other indications you see the usage of TDM1? Anyone can take it. Any personal experience in stomach HER2 positive after first line or GB HER2 positive?
So, I mean, we don't have that degree of data, but one place where sometimes in HER2 mutated lung cancer, at least we have seen some waterfall plots that this drug can produce responses. In GI, I don't think I have seen, I don't have experience, I'm not aware of any good data.
Okay. Anybody else has any experience with? No.
I have used in one patient in GB.
GB. And how has been the response?
Not good. I mean, on trastuzumab only, it was a wonderful response. 9 months patient did well along with the paclitaxel. Okay. But after that, the second line TDM did not work. Instead, I tend to use capecitabine and lapatinib. That worked really better than that.
Okay.
But this is an anecdote. I have one patient experience only, not more than that.
Okay.
In Marianne study, whatever you told, it has been used in first line. At par, you are having PFS and OS in comparator arms. But what is important is the duration of response. It is more with the TDM1 because it is persistent response which is not found in trastuzumab and taxane, and even though we are adding pertuzumab, we are not getting much benefit. That's why it is better. Like in first line also we are getting duration of response is very high and prolonged.
Right. So I think the way forward is really good for TDM1. We'll be having more and more biosimilars, and that will increase the patient's access, and of course we'll have more trials also coming up. So with that, I want to conclude. I really thank all my panelists for the wonderful discussion.
So I think this ASCO we have seen about the ADCs. So and ADCs is the way. And so nobody after Zydus probably in India is thinking of preparing for another biosimilar ADC. So Zydus has a long way to go. And from the panelists' opinion, so we need to have some cost structure so that after 1.5 years or so, the patient either they get a support or free or more access to the drug. So that's more important. Thank you so much.
Thank you.